Placenta accreta spectrum covers a range of clinical conditions where the placenta is attached or embedded too deeply into the lining of the womb. The condition is rare and affects approximately 1 in 2,000 pregnant women. However, placenta accreta is becoming more common due to the increased number of babies delivered by caesarean section. In order to understand placenta accreta spectrum, it is useful to understand the anatomy of the womb. The womb, also referred to as the uterus, consists of 3 layers. The endometrium, which is the innermost layer, the middle muscular layer, which is the myometrium, and the outer layer, which is the uterine serosa. When an egg is fertilized, it begins a 5-day journey, traveling from your fallopian tube down into your uterus. As it travels, your progesterone hormone levels rise, which help prepare the uterine lining for pregnancy. Implantation is a process in which the developing embryo, the blastocyst, makes contact with the uterine wall and remains attached to it until birth. The inner cell mass of the blastocyst forms the embryo. The outer cell mass becomes the placenta. The placenta is a temporary organ that connects the unborn baby to the mother via the umbilical cord. It provides oxygen and nutrients to the baby and removes waste products. In a normal pregnancy, the placenta will separate from the lining of the womb after the baby has been delivered. In placenta accreta spectrum, the placenta is abnormally attached to the lining of the womb. This means the placenta does not separate easily or at all after the baby is born. Our understanding of placenta accreta spectrum has changed and improved in recent years as a result of ongoing research into the condition. Previously, placenta accreta spectrum was divided into 3 conditions, namely placenta accreta, placenta increta, and placenta percreta, depending on how deeply attached or invaded the placenta is to the muscle of the womb. However, now we understand that it is more likely that placenta accreta is not a condition of abnormal placental invasion. Rather, the placenta invades normally into an injured uterus, such as from previous surgery, and becomes abnormally attached. Research is ongoing to better understand the condition and how it happens. Normally, the placenta is separated from the myometrium by a thin layer called the decidua. However, in placenta accreta, because the decidua is injured, the placenta grows too deeply and attaches to the muscle of the womb. Placenta accreta spectrum almost always develops in women with 1 or more known risk factors. This is most commonly a caesarean section. The higher the number of previous caesarean sections, the greater the risk. Women who have a low-lying placenta, a condition called placenta previa, and a history of a previous caesarean section are at highest risk of developing the condition. Where the placenta is close to the cervix, but not fully covering it, is referred to as a low-lying placenta. Where the cervix is completely covered by the placenta, it is known as placenta previa. While most women with placenta accreta spectrum have a history of a caesarean section, other risk factors include fertility treatments such as IVF, previous surgery for miscarriage or D&C, having had previous removal of a uterine fibroid, a surgical procedure known as a myomectomy. An ultrasound scan is used for antenatal diagnosis of placenta accreta. In expert centres, ultrasound will pick up on around 9 in 10 cases during the pregnancy. Approximately 1 in 10 women will not be diagnosed during pregnancy, and the diagnosis is only made either at the time of caesarean section or following a vaginal delivery, where the placenta does not separate from the lining of the womb. Most women will have no symptoms. However, some women may have vaginal bleeding, but not all women will experience this. Once your medical team suspect you have placenta accreta spectrum, you will be monitored closely by a specialist team. Sometimes admission to hospital as a long-stay patient is required, for example, if women have vaginal bleeding. While placenta accreta spectrum can only be diagnosed at the time of the birth, suspecting the diagnosis before delivery is important, as it allows the appropriate management and treatment plan to be put in place. Sometimes an MRI will be arranged. While ultrasound is the best test to examine the placenta, some teams rely on MRI as it may allow them to get more detailed images of the relationship between the placenta and other organs close to the womb, such as the bladder. If you have an MRI, your team of doctors will use both the ultrasound and MRI images together to plan your surgery. Both ultrasound and MRI are safe during pregnancy and do not harm your baby. You may be prescribed iron during the pregnancy to optimise your levels for the birth. During your pregnancy, you and your baby will be monitored closely. You will be cared for by a team of doctors and midwives with a specialist expertise in placenta accreta spectrum. In most cases, your baby will be delivered a few weeks before your due date. Usually, the birth is planned to take place between 34 to 37 weeks to avoid the need for emergency delivery. In rare individual cases, earlier delivery may be necessary. Doctors make an individual decision for each woman based on a variety of factors. Where a diagnosis of placenta accreta spectrum is suspected, your baby will be delivered by caesarean section. To prepare for surgery, you will have a spinal or epidural anaesthetic or a full general anaesthetic. During a spinal or epidural anaesthetic, an injection is given into the back and you are numb from the chest down. This means you will be awake for the delivery of your baby. During a general anaesthetic, you'll be asleep for the delivery. This may be necessary in some cases to provide adequate pain relief or if heavy bleeding is anticipated. Before the operation, you may have an arterial line placed in your wrist, as well as a number of other drips in your arm. In some cases, a central line is inserted into your neck. A central line is a long, thin, flexible tube placed in the neck through which medicines, fluids, or blood products can be given. A central line may stay in for a number of days, if required. Ureters are tubes that carry urine from the kidney to the bladder. In some high-risk cases, there may be an increased risk of damaging the ureters as they lie very close to the womb. To reduce the risk of injury, a small tube may be placed in the ureters to protect them during the surgery. These may be removed at the end of the operation or can be left in for a few weeks afterwards. As the risk of bleeding is high during surgery for placenta accreta, it may be necessary to place balloons in the blood vessels, which supply blood to the womb. These balloons may reduce blood loss during surgery. They are usually inserted through a blood vessel in the groin before surgery by a specialist doctor, inflated during the operation and removed at the end of the procedure. Approximately 4 in 5 women will have an elective planned delivery. In some circumstances, an emergency delivery is necessary. This occurs in approximately 1 in 5 cases. The most common reason for an emergency delivery is when women start bleeding or get labour pains before their scheduled delivery date. A planned delivery is safer for both mother and baby as it minimises the risk of heavy bleeding. If you are scheduled to give birth before 34 weeks, you will likely be given steroids, which help to mature your baby's lungs. The surgery may be through an incision similar to a normal caesarean section, called a transverse incision. or it may be performed through a large midline incision on the skin from above your belly button to the bikini line. The baby will be delivered through an incision on the womb away from the placenta, and the placenta is left undisturbed. This minimises the risk of bleeding. Your baby may need to spend some time in the special care unit. The length of the stay will depend on how early the baby is born. In placenta accreta spectrum, once the baby has been delivered, the placenta stays firmly attached to the womb, and there is a high risk of bleeding if attempts are made to remove the placenta. Therefore, in some cases, the safest option is to remove the womb immediately after the baby is delivered with the placenta to minimise the risk of blood loss. This operation is called a hysterectomy. The need for a hysterectomy depends on many factors, such as the type of placenta accreta spectrum and what your team consider the most appropriate management for you. In cases where you are awake for the birth of your baby, you may be put to sleep while the hysterectomy is completed. In a subtotal hysterectomy, only the womb is removed. In a total hysterectomy, your womb and cervix are removed. Usually, the fallopian tubes are removed. Not all women with placenta accreta spectrum will require removal of the womb. In some cases, other treatment options are suitable. These are myometrial resection or leaving the placenta in. A myometrial resection is possible when the area of placenta accreta spectrum is in a certain part of your womb, for example, higher up in the womb and away from the cervix, and the area is not too big. The placenta may have grown deeply into the lining of the womb only in this area. The rest of the placenta may not be stuck. In these cases, this area of the muscle can be removed along with the placenta. The womb is then preserved and closed in a similar fashion to a caesarean section. This is called a myometrial resection. If the placenta starts to separate by itself, a gentle attempt to remove the placenta can be made. However, this may be associated with heavy bleeding and will only be attempted if the placenta separates naturally. In some parts of the world, placenta accreta spectrum is managed by leaving the placenta inside the womb, where it may absorb over a few months. This is not standard practice in most countries, and women may need a hysterectomy at a later date due to infection or vaginal hemorrhaging. Heavy bleeding may require the need for a blood transfusion. Approximately 4 in 10 will require a blood transfusion. In order to reduce the need for a blood transfusion, your own blood may be transfused back to you in a process called cell salvage. Infection of the wound following surgery. If an abscess develops, this may require surgical drainage. Following delivery of the baby, you may be admitted to the high dependency unit for close monitoring and observation. During this time, you will likely have a catheter in the bladder and may have a number of drips in your arms and neck. Where the surgery has been uncomplicated and the blood loss minimal, you may only need to spend 3 to 4 nights in hospital after the birth. However, if there was a complication or heavy bleeding, admission to intensive care or a longer hospital stay may be necessary. The risk of death is rare when the diagnosis is suspected during pregnancy and you are being looked after by a specialist team. Your baby may need admission to the special care unit for support with breathing and feeding. This means that you may be separated from your baby following delivery. However, where your surgery has been uncomplicated, you might be able to visit your baby in the special care unit a number of hours after birth or the next day. Many women have reported this can be a difficult time after what may have been a challenging pregnancy. After your surgery, there are several different pain management medications available to you. It is important to take pain relief regularly to prevent breakthrough pain. Women who have experienced placenta accreta strongly advise effective pain relief management. This may be something you can discuss with your care team before the birth. You are also at risk of developing a blood clot in either the leg or lung and will therefore be prescribed blood thinning injections by your team. To minimise the risk of developing a blood clot, you should wear compression stockings for 6 weeks and take daily blood thinning injections if these are prescribed by your team. The surgical wound will take approximately 6 weeks to heal. However, this may take longer, especially if you have had an infection. Pelvic floor physiotherapy is recommended. You should be referred to a physiotherapy team during your pregnancy to prepare you for the birth and your recovery. Our research has found women find their physical and mental health benefits from working together with a physiotherapist. Women may go home before their baby has been discharged from the special care unit, so this can be a very challenging time for mums and their families. For many women and their families, they may have both physical and mental health challenges after pregnancy complicated by placenta accreta spectrum. These challenges may last for many months or even years. Therefore, your team should arrange a postnatal review for you a few weeks after the birth, but may also offer to see you as needed into the future. Placenta Accreta Ireland is an advocacy and support group for women and their families who have been impacted by this condition. We encourage you to get in touch if you feel you would benefit from speaking to advocates and women with the lived experience of placenta accreta. We support women and families with different experiences of placenta accreta, including bereavement and loss.